Hello, I'm Dr. Tyler Hughes. I'm Secretary of the American College of Surgeons, and I'm a clinical professor of surgery at University of Kansas School of Medicine in Salina, Kansas. I'm joined today by Dr. Jose Prince, who is a pediatric surgeon. He serves as Vice Chair of Surgery and System Chief of Acute Care Surgery and Pediatric Surgery at Northwell Health. He is Associate Surgeon-in-Chief at Cohen Children's Medical Center and Associate Professor of Surgery and Pediatrics, Zucker School of Medicine at Hofstra Northwell. So glad you could meet us today, and thanks for lending your expertise.
Thank you so much for having me. It's really an honor to follow up on a conversation you and I have had, and that I think many of us are having around the country, which is how to think about the impact of COVID on children as the pandemic has widened across the United States.
Well, it certainly is a propitious time for us to bring pediatrics and pediatric surgery back into the fore. At the time of this recording, lots of schools are just beginning to open, and since pediatrics goes from 0 to 18, that even includes freshmen in college and sophomores. Right. So, one of the things that's floating around on the internet and sort of in general is the common assumption that kids don't really get COVID, or if they get it, they don't get very sick. You were right there in New York, sort of at the epicenter during the biggest and first wave in the United States. Can you give me your take on how this affects kids and how it affected you as a pediatric surgeon during that very difficult time?
It does raise so many questions, and it was such a unique moment, certainly in my life as a physician, as a pediatric surgeon, and being here. Our children's hospital, Cohen's, is in Queens, which, as more and more data gets released, we're seeing that in some parts of Queens, over 50% of the population is testing positive on antibodies for COVID. So it really goes to the heart of what you said. This was really an epicenter of that initial burst. And so we've had quite that experience initially of the burst, and now also to see what it looks like on the other side a bit. And then, like the rest of the country, starting to think about what does it look like in this next phase in the fall as we think about school reopenings. You mentioned, pediatric surgery. One of the great privileges of being a pediatric surgeon is the tremendous range of children's ages. And so the impact was different for kids during the peak period here and across the country, and then after also that acute infection. And the data seems to be coming out that, just like so much of pediatrics, they're not just little kids, that when we think about maybe children under the age of 10 and the impact of COVID on them looks one way, that our middle schoolers and high schools might look a little differently and maybe close to the adult experience. When the pandemic hit its peak back in April for us, we had an initial wave where we would see 20 or 30 children that were COVID positive with acute respiratory infections a week during those initial several weeks of the peak of the pandemic. And that was really a tiny number of children relative to the population and relative to the thousands of adults that were hospitalized with COVID. And that really gave all of us, at least at some level, a sense that thankfully the children were being protected from the infectious complications, at least the more severe part. There were some children, a small number, that were ill and had significant respiratory symptoms. We had one child that required ECMO support for the acute COVID infection from a respiratory point of view. But then what we saw was that in 3 or 4 weeks after that initial spike in the acute respiratory infection, we had a whole new disease develop, which has now been named by the CDC and others, the multisystem inflammatory syndrome of children, MISC, people are calling it. And we then had a second peak almost of very sick kids with this condition. And we had another over 50 kids present over the next several months. So it mimicked that peak at its worst of about 20 kids a week coming in, staggered about a month afterwards. these children had IgG positive exposure to COVID. So they had COVID, but many of them were asymptomatic with that initial infection from a respiratory point of view. So it was almost a different cohort of the disease. And the hallmark of these kids when they presented was fevers, most of them for many days, abdominal symptoms, which as a pediatric surgeon was initially confusing for us to make sure we did the right thing. None of them really required surgical care for the abdominal presentation. So they'd have abdominal pain and diarrhea, almost 100% of those kids. But none of them required surgical treatment for any of the abdominal inflammation that they were experiencing. On the blood work, we saw significant inflammatory marker changes, and then they were in shock, really, to complete that diagnosis of MIS-C. So about 2/3 of those children ended up requiring vasoactive medications in an ICU setting. Probably 80% were in ICU, and about 2/3 of them required vasoactive medications, and about 20% of those required airway control as well as part of their shock syndrome. And we published our initial experience in the Journal of Pediatrics. Christine Cohen, one of my colleagues who's a pediatric ICU and cardiology specialist for children, really led that effort as we tried to understand this new disease that was developing right before our eyes. Thankfully, the kids responded well to IVIG and other treatment protocols that we developed because it's similar in some ways to Kawasaki disease. And so there's some background for us clinically to think about how to treat it. But it was really a medical management and not a surgical management. The challenge was for us that children were still coming in with appendicitis during the pandemic at the same rate as they came in before we had the pandemic. So trying to distinguish both ways, that we wouldn't ignore a child with MISC and misunderstand what we were dealing with, and on the other hand, that we wouldn't call kids with appendicitis MISC and not operate when perhaps that was really what they needed from a surgical management point of view.
So let me follow up on your last comment, and that is, you know, if we see this kind of secondary syndrome of MISC in some percentage of the children who go back to school, general surgeons and pediatric surgeons all over the country are going to be seeing a child with fever, abdominal pain, and shock, which looks a lot, probably will look a lot like septic shock from some other process. What is your kind of general algorithm? What is your general algorithm when you are consulted on that? What do you advise the rest of us who may get called into the ER for a pretty sick kid in the middle or shortly after a peak locally?
Yeah, so obviously it depends on the resources and where you're practicing. You know, I have the privilege of being at a children's hospital, so we have ready access to ultrasound in the ER as an initial evaluation for abdominal pain in children. So that's a common go-to test for us. We know from our experience so far with the MISC patients, you don't really see high drops of the gallbladder. You do see inflammation of the bowel. The terminal ileum can be inflamed in what you see, but the appendix itself doesn't seem to be as caught up in the process from at least the initial ultrasound work that we've done. And on the children that ended up getting a CT scan or an MRI as part of their evaluation, it also shows basically that inflammation of the intestine, but it doesn't show you the more traditional signs that we often see with appendicitis, you know, in terms of a focal abscess if it's more advanced, which is typically what you're going to see for a child in shock. You're often talking about a ruptured appendicitis and not the simple appendicitis. So that helps us to distinguish. The other thing I would say is that as a surgeon, there's a new lexicon of tests that sometimes then come in looking at D-dimers, fibrinogen, and trying to understand the inflammatory process that's taking place in the child. And really our colleagues on the medical side in the ICU we have a very delineated now protocol for the laboratory evaluation for these children. It also includes echocardiography because of the shock component. And so you also see cardiac dysfunction as part of this as well. So some of this will overlap, but the information will start to point you towards the direction that they're perhaps, again, depending on where you are in the country and the timelines to get test results, they're IVIG positive for COVID, meaning they had COVID at some time 3, 4, 5, 6 weeks ago. That seems to be the time frame, we think. and now they have this inflammation with shock, with abdominal symptoms, but not a targeted surgical pathologic finding on imaging.
Sounds like this could be a real challenge for lower resourced hospitals where there's no pediatric surgery or even pediatrics itself available.
Some of these children, thankfully, it's very rare still, the MISC. By an overall population rate, it's quite low. But the kids get sick pretty quickly and pretty severely for a couple of days, and then they turn around. So having the right PICU or ICU support for children, depending on the environment you're in our country, really can make a difference for these kids.
Yeah, it sounds like the old high index of suspicion phrase is important here.
Yeah.
What's their abdominal exam like that you experienced? Do they have guarding with this and rebound so that you're really looking at, is this an acute abdomen sort of picture? Is it more like the advanced ileus where, you know, they have kind of plus minus rebound and you're going, not an acute abdomen, obviously sick?
Yeah, it's more, the exam's not typically that impressive in most of the kids from a peritoneal signs point of view, where they have a rigid abdomen and you're really worried about what's going on. They tend to have this more diffuse discomfort and tenderness as you're examining them. The average age of the kids that we took care of with MISC was 9 years old in the study we presented. But the range was from as little as 2 or 3 year olds to the great big 17-year-old teenagers. So obviously also the exam component changes depending on the age of the child, which is common for us in pediatric surgery. What
general advice do you have for surgeons and kind of in general as school starts up? What are you telling your community around there about if children are vectors, how to protect the teachers, et cetera? What are the stories going around there? Because the memories must be very sharp from April there.
Yeah, it is a really complicated question, which I don't think any of us has a crystal clear answer for. I also think it looks very different when in each school and each community, because the resources and, you know, obviously there's been also during this time such a conversation in our country about social justice and the inequities both of this disease and other problems, and that comes into our school system as well. So you know, it might look very different at a sparsely populated private school that has a lot of space than an urban, really densely packed school. What I think the data seems to be pointing, there's studies from Korea, there's some European and other Asian studies that have been coming out throughout the summer trying to look at the population's base. It seems that we can cohort kids at least into 2 buckets, that the children in the primary schools, you know, the kindergarten through 5th grade, the 0 to 10-year-olds, they can get the infection and they can have the virus. So that there is certainly the possibility they could transmit, although there's some suggestion maybe they don't transmit quite as much as we'd think. But that they seem to be in one bucket. They don't seem to get very sick from it, and they don't seem to be vectors as far as the best studies can seem to show, at least for the symptomatic kids that were tracked in Korea. It's really an open question for the asymptomatic kids that never got tested, and we don't really know what's happening there. So I think for grammar schools, especially since most of our grammar schools, the geography that the kids are coming from tend to be clustered around that school. So the distances and the mixing in the community might be a little bit more easy to track after the fact. I think we can expect that there will be some positives, obviously, as we've seen across the country. But the category in the primary school seems to be in one group. The middle schoolers are kind of caught in the middle, like is usually the case, even behaviorally. And the high schoolers are much more like adults start to be, and depending on the high school you're in, you know, when you're looking at some of the bigger geography where kids are coming from, different communities blending in. And then college is a whole nother world. You know, we can see what great institutions like a Notre Dame is struggling through right now at the time that we're talking about, and the decisions that major universities are making where you're talking national, international students coming in, and really an adult-like profile in terms of the ability to get sick and to convey it. So I don't know that I gave you an answer. I think I know in my community around here, the answer is as different as the school and the neighborhood that I'm interacting with. So that, the private schools are doing one thing, the public schools in different zones, because our hospital is in New York City, but we're right on the Nassau County border. So then you have different groups. It's really a varied response. How much is virtual? How much is full-time? And how much is in between as a hybrid model?
Yeah, it sounds like it's very important that you take a localized approach, use the recommendations appropriately, and then watch carefully for the result. Be willing to change.
I think the biggest thing will be, especially for the high schoolers and the middle schoolers, is the mask wearing and everything you can do to ventilate the space that the kids are in. I personally, my sense of the data is I'm not as worried about, the lunchbox, that's how it's going to be the vector. I think it's much more an airborne disease, and that's really where the effort should be made. And I think, we have to be honest and realistic about what it's like to try to get a kindergartner to wear a mask all the time, and what the challenges are there, versus the high school kid who we can work with and should know better if that's really what we're all on the same page with.
Well, let me switch gears just a little bit. As a pediatric surgeon, you're a subspecialist and a member of the college. How was the college helpful to you during these last several months? And what do you think the benefits are for a pediatric surgeon to be involved in the college?
College really jumped in, especially, one of my hats is as a trauma medical director at my institution. The Committee on Trauma really organized an ad hoc gathering with senior leadership from the American College of Surgeons, as we were concerned about the stability of the trauma system in the New York City and the greater metro area, as the ICU capacity really disappeared during the peak of the pandemic. And it was so helpful to know that really smart people who thankfully had maybe a different amount of energy and time to think about the problem we were facing, because they weren't in the eye of the storm at that point, were working on it, and that we weren't alone, and that hopefully whatever we were experiencing, we were also trying to transmit back from the regional perspective to try to help guide what was maybe going to come down the road nationally. So I really, in the midst of it, it was really an important part of what it meant to be a surgeon in this community, to interact with the American College of Surgeons. They really came through in that sense. And then personally, as a pediatric surgeon, I have benefited in so many ways from my membership in the American College of Surgeons. I was awarded a research fellowship from the American College of Surgeons for 2 years when I was a resident at the University of Pittsburgh. It was very impactful in terms of continuing to push me along the path to try to develop as a surgeon, scientist, academic surgeon. So really from the beginning in my career as a surgeon, and then now as a subspecialist, some of the most vibrant panels and sessions where we get to go over the cutting edge pediatric surgery science is at the forum when we present our work there. So I also think that as pediatric surgeons, we're jacks of all trade. We do all kinds of different things. The surgical forum and the interactions with our other colleagues, who often the companies develop technology not for pediatrics because the market space is so small, but really for the rest of you. That sense of continuing to grow with what the rest of the surgical community is doing is really an important part, I think, of our field maintaining itself current and advancing forward. So it's really a great union. And I find it very helpful to go back and forth from the larger community to the smaller community I'm a part of, maybe with a pun intended.
Well, thank you so much for your time today, Dr. Prince. For those of us who weren't in the eye of a storm, we applaud your courage and your persistence in the face of great adversity. It's also very worthwhile because there's so much that we don't know about how things are going to go, to talk to people who've been there and can give us some specific insights. So thank you very much, and we wish you all the best in your career, and especially as the fall comes upon us. Take care of yourself.
Thank you so much, Dr. Hughes.
Thank you.